Good afternoon. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. We are celebrating our 10th year. Yay. And prior to that, many of you know me from MPN Research Foundation in Chicago. I was there for almost 9 years. With us today is Dr. John Mascarenhas from Mount Sinai in New York. We hear great things about him. And of course, personally, I think he's a wonderful MPN specialist and good friend to us. And he's here today to talk specifically about myelofibrosis. We are very happy that you're here, John. Thank you for taking the time out to join us.
Thanks, Ann. Thanks for inviting me. I'm really pleased to be here and talk about myelofibrosis. I've been in the space now for over 15 years, getting to 20 years soon, and I've watched the field change and grow in a positive way. So I'm excited and enthusiastic about what's happening and the potentials for our patients, and I'm hoping to convey that and to answer some questions today. Maybe I'll just start, as you suggested, just sort of giving a high level, sort of where are we with myelofibrosis today in 2023, which is very different than in 2005 when the JAK2 mutation was discovered, and then in 2007 when we started to develop rapidly some data for JAK inhibitors, to 2011 where we had our first JAK inhibitor, ruxolitinib or Jakafi, approved for myelofibrosis, 2014 for polycythemia vera, and then 2019 for fedratinib or Inrebic, and then 2022 for pacritinib or Vonjo, and then likely next month, 2023, we're going to have our fourth JAK inhibitor, momelotinib, approved. So it's really exciting to sort of see the field move from the biologic understanding to the clinical development of these JAK inhibitors that really afford our patients significant benefits in terms of spleen and symptom and even survival benefit. And now with pacritinib and momelotinib, we're even talking about anemia benefit, which we didn't really talk about with JAK inhibitors previously. And really, this is just, I think, the beginning. What the group will see and appreciate is that the new era of combination therapies is upon us, and those are approaches like pelabresib, the pan-BET inhibitor. These are oral drugs that can be added to Jakafi to synergize to get deeper responses, hopefully more durable responses and disease modification. Drugs like navitoclax, the BCL2 XL inhibitor, and then drugs that could be used even alone, like navtemadlin, the MDM2 inhibitor that induces apoptosis or programmed cell death into myelofibrosis cells, and then imetelstat, the telomerase inhibitor, which is an infusional agent, which is in a phase 3 testing for overall survival. And then many more drugs that are in early stage development that look very promising. I think the benefit we have today than we did not have 20 years ago is we understand the biology more today. And with that understanding comes significant advances in more rational targeted therapies. I'm a firm believer that it's with this type of approach, of translational approach, that we're really going to make headway into treating myelofibrosis, and we're seeing it. I think there's still a lot more to do, and that's why people like myself and many others are dedicated to showing up every day to try to understand the disease and develop new therapies that are going to be, hopefully one day we'll talk about curative therapies outside of transplant. So it's a lot of exciting topics. I'm ready to jump in and talk about whatever comes up.
And there's quite a bit to come up here, but thank you for that introduction. First question right off the bat, and you were kind of talking about this, is what treatments for MF are showing great promise that you're currently using in patients in reducing symptoms, but also having a molecular result?
So I would say there's a number of drugs that are in phase 3 testing. So that's like the last stage before the FDA will approve a drug if the study is positive. So drugs to be aware of are the drug pelabresib or pelabresib, and that's an oral drug that is added to Jakafi in the upfront setting. This is in patients who've not seen a JAK inhibitor. So the two drugs work synergistically together. They really work as complementary drugs in reducing the disease process in terms of not only deeper spleen responses and symptom responses, but also a third of the patients achieving bone marrow fibrosis reduction. And then, almost quarter to a third of the patients achieving reductions in the mutations, the driver mutations, whether that's JAK2, MPL, or CALR. And some very cool correlative science that was presented at the American Society of Hematology meeting by friend and colleague Joe Scandura, who's right next door at Cornell. And he showed in his presentation that some novel biomarkers looking at distancing of megakaryocytes, making sure that they get further and further apart on the bone marrow biopsy as a new biomarker in the bone marrow to give us a sense of whether we're modifying the disease. And to me, that's also very exciting. And I think underappreciated. We need to understand the biology of the disease. And then when we apply therapies, are we affecting the biology? Is that going to ultimately translate to better lives, longer lives, better quality of life? So those studies are ongoing, but we got a glimpse of that with pelabresib. And what it taught us is that these drugs, and when I say these drugs like pelabresib, I think are more attuned to attacking the malignant stem cell. And that's what it's all about in 2023 going forward. It's not just about affecting some of the byproducts of the disease, like the inflammation, which is not unimportant, but is only part of the story. It's actually going after the cell of origin, the stem cell and progenitor cells of origin. These are the maternal and paternal grandmother and grandfather cells of the blood system that give rise to all of the cells that are part of the diseased process. And going after them, they're like the generals of the army and trying to take them out. But to do that, you have to understand how they behave, how they evade therapies, and what their vulnerabilities are. And that's what a lot of the translational research that we do at Mount Sinai, a lot of the other participating centers, and within the research consortium, that's an NCI-funded grant that Ron Hoffman holds, which there are a number of really dedicated and smart laboratory investigators like John Crispino, Ron Hoffman, and Rita Migliaccio, and Ross Levine, and many others, but those are some of the prominent ones that are helping us understand how do we get to that stem cell. Almost like a sniper, how do we take that stem cell out and leave the good ones behind so that normal blood cells can get developed? And are there biomarkers that we can use, like distancing of megakaryocytes, that give us a sense? So we saw that with pelabresib. That was very exciting. We want to follow that up, and that's what we're going to see in the MANIFEST-2. That's the randomized phase 3 study. We think that the readout, at least the initial readout from that study, will be in probably September, October this year. So we'll have a sense of how active that drug is compared to a control arm, which would just be Jakafi and placebo alone, and whether these biomarkers really translate to clinical outcomes that matter, like survival. That's one example. Pelabresib, I'm super excited about. Navitoclax is another really great drug, very rational. You inhibit a protein called BCL2 and BCLXL. And those proteins are pro-survival proteins. The cancer cells ingeniously upregulate these proteins and keep themselves alive where we don't want them to be alive. So we want them to die. And how do you do that? Essentially by convincing them it's time to die, something called apoptosis or programmed cell death. It's almost like encouraging them to commit suicide. And in one way in doing that is to block those pro-survival proteins. And that's what a drug like Navitoclax does, and does it very effectively. And a lot of the preclinical studies that we see for these trials look really good, but that doesn't matter because those are in mice. And until you prove it in humans, it's really not really relevant, but it gives us the confidence to take them into the clinic. So I'm excited to see what the Transform studies tell us. Those are ongoing phase 3 studies, both in the upfront, so in the JAK inhibitor naive population, but also in the relapse, the previously treated JAK inhibitor population. So keep an eye out for those. And then, as I mentioned, navtemadlin, the MDM2 inhibitor, this is an oral drug. Again, same concept, trying to convince the cells to commit suicide. How do you do that with navtemadlin? You upregulate a protein called p53. p53 is the master regulator of cell fate. And if you can do that effectively, you will induce cells to die. And again, it's preferential death, the malignant cells, and not just the end product malignant cells, but the primordial disease-initiating malignant cells. We need to get rid of them. And this is really one very innovative and ingenious way of doing that, because they remain alive by expressing proteins that negatively regulate p53. So it's like a double negative. We give an inhibitor that inhibits a negative regulator of P53. So we turn on P53 and we encourage those myelofibrosis stem cells to die. And that's the purpose of the Boreas randomized phase 3 study in patients who have failed ruxolitinib and get randomized to this nab-to-madeleine drug versus best available therapy. Definitely keep your eyes on that, because I do think that that's a promising agent. And then imetelstat, which is a telomerase inhibitor, and telomerase is an enzyme that's almost exclusively, it's actually an enzyme that's seen in a lot of different cancers, but in myelofibrosis and in myelodysplastic syndromes, it's almost exclusively expressed in the malignant stem cells and not in normal stem cells. So there's a window of opportunity to poison that enzyme with this drug telomerase. And that enzyme is known to add repeats of DNA to the ends of chromosomes. So when cells divide, you lose a little piece of that chromosome at the end with each division. You get to a certain point, a certain number of divisions, where that cell no longer has enough chromosome material to keep dividing, and the cell is encouraged to commit suicide, apoptosis. But cancer cells have figured out a way to get around that, and they express too much telomerase, and that keeps them going forever. It's like the fountain of your youth. So what imetelstat does is it poisons that enzyme, and it preferentially induces the malignant stem cells to commit suicide. Again, as you can see, it's a common theme, different angles, common theme. And in phase 2 data, that there was very encouraging results that looked like there was a survival benefit to imetelstat. So in the phase 3 study, we're seeing, is that true when you compare it to a control arm of patients who don't get imetelstat? And are we going to be able to meaningfully improve the survival of patients? So in 2023, it's not just spleen and symptom; those are important. It's also anemia, it's reduction in fibrosis, and ultimately improvement in survival. And a lot of different drugs that are really in the latest stages of clinical development.
That's remarkable. It's remarkable, and I can't thank you enough for explaining this. We try to get this information out any way we can, through our partners and through our MPN specialists. And thank you very much for that explanation. That was great. Okay, so this person, of course, everybody wants to know about progression, and you just touched on it. And so, are you seeing drugs that are inhibiting, and that's the only word I can come up with at the moment, or seem to be keeping the patient with MF in the same place? Like they're not progressing. Can you speak to that a little bit?
Yeah, so I mean, I think the answer is sort of, and I say sort of because in order to really prove that a drug is stopping progression, what we often call PFS, or progression-free survival, you need a control arm of patients so you can say, yes, this is clearly doing it, rather than this is an artifact or some confounding variable that's making it seem that way. So I'll give you a prime example. With imetelstat, when we looked at survival, there was a 30-month median survival in the patients who got on that study. They had discontinued Jakafi. These were patients who were quite ill. And that was favorable when looking at the lower dose of the drug that was used, was 20 months. And very favorable when looking at 5 independent retrospective studies that would suggest the survival of patients that are that advanced could be somewhere between 12 and 15 months. So it did look like there was a survival benefit. When you looked at progression-free survival, sort of stopping or slowing down the progression, again, there was a sense that we were having progression-free effects on the diseased, on the disease cells, but on the patients. And that was very encouraging. But, I'm the first to admit, until you have a phase 3 study that clearly shows in the 2 arms that there's an improvement in that variable, we still have to wait to see that result. But I do think that we have drugs that do that. Are there surrogate, you'll hear a lot of times when you talk to investigators and people in oncology, you'll hear certain terms that maybe I'll help give some definition to so it's more meaningful. So survival is an obvious one, and that starts at the time of treating someone. Progression-free survival is, can we limit the number of patients and or the duration till someone develops AML or develops some massive clot or something that is disease-altering or tragic. And then surrogate markers. We say that all the time, and I'm not always sure that everyone understands what that means. We're always looking for surrogate markers. That could be the mutation levels going down. That could be bone marrow fibrosis reduction. That could be megakaryocyte distancing in the bone marrow. That could be something new, like cytokine levels going down. So we are in these trials, we're always drawing blood, looking at bone marrows, trying to figure out, are there markers even early on in the first 3-6 months of therapy that will tell us, well, these patients are clearly going to have the best benefit in survival. So we won't waste the time of these other patients that are not achieving these biomarkers, or are there biomarkers, are there proteins or mutations up front that will tell us, well, these patients will enjoy the best benefit with this agent, whereas these patients will enjoy the best benefit with this agent, so we won't waste their time and their energies. We'll put them in the right treatment algorithm. And although I would say we're not there yet, that is part of the process of what we're trying to accomplish with these studies, and to try to create algorithms that will then help us put patients into the right lanes so that they're not going down a dead end and they're in the right avenue. So progression is one of them. I think most people will agree that if we can reduce the amount of disease in the body of any cancer, but let's say myelofibrosis, then they're likely to have less progression and be at less risk for progression. And one of those markers is reduction in JAK2 V617F, for example. So you'll see in most studies, they will say, well, 42% of patients had a reduction in JAK2 allele burden of 20 or 25% or more. So you can measure in the blood, and any patient, can have this done by their treating physician. They can measure what is the percentage of mutation you have in your blood, whether it's JAK2, MPL, or calreticulin. And with treatments like imetelstat, I'm just giving that as an example. You could say the same with navtemadlin or any of the other drugs. There are a proportion of patients that will have a decrease in that mutation as a surrogate for decreasing the amount of disease in the bone marrow. Because unlike breast cancer or lung cancer, where you can do a CAT scan or a PET scan, and the concept is easy, to sort of wrap your head around. In breast cancer, there's a mass in your breast. It might go to your armpit and then metastasize outside, and you can stage it. Well, in myelofibrosis, unfortunately, it's not that simple. It's kind of complex because the disease is throughout your bone marrow. It's basically metastatic at the time of diagnosis. So we don't have imaging to stage someone. So how do you do that? How do you get a sense of whether you're having a genuine and meaningful impact? Well, we think that one of the ways is looking at the amount of the driver mutation as a surrogate for the reduction in burden of disease in the bone marrow. Now, I won't rest, and I don't think anyone in this field is going to rest with the results that we have so far. What we want to see is 0%. We want to see reduction in mutation level to the point where you can't detect it. And then we would have a lot of confidence that patients would have a better progression-free survival, a better overall survival. But we take steps, and to a patient, it might feel glacial, but we take steps forward to try to understand the biology and these markers and these surrogates, so that we have confidence we're going in the right direction, and then we build on that.
Okay. So one of the questions I have, and I actually know a gentleman who was diagnosed with primary myelofibrosis several years ago. And this patient is saying, I have no symptoms other than the blood work and, what the physician discovered. And they've opted not to treat him. And I wonder, or this patient wonders what your opinion is on that. I mean, if you diagnose a new patient with primary MF, and do you immediately start treatment, and what would that treatment be? Or do you wait and see? Like, over the years, I've heard that expression quite often. What would you do?
So it's a great question. It's also one of the trickier questions to answer. And I'll preface anything I say by, I'm speaking in generalities, so you have to take everything I say with a grain of salt. If you're a patient listening, you are a unique person, and no two people have the same presentation, clinical course, or response to therapy. So it really has to be individualized. But with that, I'll say that if you look at guidelines like the National Comprehensive Cancer Network guidelines, which are throughout the US, they're independent of influence from pharmaceutical companies, et cetera, and they provide what is supposed to be objective and evidence-based guidelines for practitioners in academia and in the community for treating every type of cancer, including myelofibrosis. So there are guidelines for myelofibrosis. And you'll see if you fall in the lower risk categories by risk stratification, there are a number of tools, and many patients can go online and you can find these tools and you can plug in your own data, your own age, your white count, your hemoglobin level, your platelets, et cetera. You can put all of that stuff in, and it can give you a risk score. I would not advise doing that, however, because I think it induces a significant amount of anxiety, but doesn't actually help, in most cases, provide a sense of what to do. And what I mean by that is we have risk scoring systems because they're very helpful broadly for making decisions for patients who might be transplant candidates for go, no go for transplant. So if you're higher risk patients and transplant is on your radar and you're amenable to transplant, then one can make a very cogent argument to go forward with transplant. It doesn't really help the individual patient plan their lives, make decisions about whether they're going to, go on that cruise in a year. I mean, I wouldn't live like that because it's really misleading. These are medians, they're averages, and they don't tell the individual patient what to expect. So to be aware of people who oversell the risk scoring systems. They're helpful, but not always to the individual patient in planning out their life. When you fall in a low risk category, the recommendations are often WW, watch and wait, or sometimes people will say watchful waiting. And the idea is that unless you have a therapy that is clearly going to modify the disease course or put you in a remission, then don't expose someone to potential toxicity if it's not going to really change their outcome in a reliable way. So there are a chunk of patients that you'll meet that are lower risk, and they may not have any real symptomatology. They're early on in their disease course, and it wouldn't be unreasonable to watch those patients and not to intervene, at least now, until we have the drugs that we collectively feel confident are going to change the disease course and not cause a lot of toxicity. Now, some patients may not feel comfortable with that, and I would understand that. The idea of just waiting for the shoe to drop is not a very comforting thought. So for some patients who have a proactive personality, they may say, well, that's not going to work for me. Are there options that make me feel like I'm doing something? But of course, you don't want to just feel like you're doing something that would actually have some potential for disease modification. I think one consideration for a low risk patient who, eyes wide open and very transparent, understands that intervention doesn't always mean improvement in progression and survival, but might would be a drug like interferon alpha. And there's mounting evidence, particularly from our colleagues over in Asia, that have done some studies that have shown that if you use it, actually, and colleagues here like at Cornell with Dick Silver and others, that if you use this drug, which is a biologic drug, it's an old drug actually in many ways, but you use this drug earlier in the disease course, you may have the opportunity in some patients to modulate or modify the way that malignant stem cells behaving, and perhaps delay the onset of progressive disease. And I will say that that's not fully proven in prospective studies, so I'm careful not to oversell that. But I'm very respectful for the idea that I do think interferon is a stem cell directed therapy. I do think it has the potential to do that in a fraction of patients. We do not know a priori who the best patients are for that, although I think lower risk patients that can understand the balancing between benefit and risk and accept that, I think should consider that perhaps. So what are the downsides of interferon? Well, it can be a drug that can add toxicity, so lowering of blood counts, but also just generally speaking, patients don't always feel well on interferon. So there's some side effects, fatigue, malaise, which just means crummy. And then sometimes patients can have neuropsychiatric effects, which are stuff like depression, anxiety, mood ability, difficulty concentrating. It's not a drug for everyone. Now, you're not guaranteed to get those toxicities, but you're also not guaranteed to get success. So you have to have a certain appetite for risk and reward and understand the balancing of it, and have a physician who's aligned and is going to follow you carefully. You don't want to run right into the sunset with interferon without a good plan, a follow-up plan, expectations laid out. I would even argue family members and loved ones around you that are going to look for toxicity, because sometimes patients themselves can't gauge, if they're the ones experiencing it, they can't always fully gauge it. So it's helpful to have a spouse. It's happened more than once where a spouse has come in and said, I don't recognize my loved one anymore. Their behavior is not what what I've known for 30 to 40 years of marriage, and their temper is not appropriate. They're going to dark spaces, and the patient doesn't always see it. So sometimes it's really helpful. These are small things that can be big things to consider. But I would say, generally speaking, low risk patients, watch and wait is appropriate. It's guideline endorsed. If you are not a watch and wait kind of personality, which I can appreciate, I think interferon is appropriate. And then, I also think that there are patients who technically fall in low risk who are symptomatic, whether it might be fatigue, it might be things that people miss, like bone pains at night that kind of disturb sleep, or cramps at night in the legs. Those are frequent complaints. Sometimes it's just not feeling your age, feeling 10 years older, because you're inactive, you just can't get things moving. You're not as social as you were, you're not as engaged, maybe you can't carry on your work as you could. And sometimes those patients are really appropriate for JAK inhibitors, even in the low risk category. So it has to be individualized. You have to understand the goals, the expectations. That has to be discussed transparently with the physician. And the toxicities have to be laid out very carefully. And there's no guarantees, unfortunately.
So many questions. And you described me in some of those comments you just made, like people not recognizing who I am anymore because I've lost my mind. But anyway, I'm only making light of it, and as myself is the joke. Okay, so with all these new JAK inhibitors and several coming down the pipeline, what's different? What is different? What is the mechanism of action? What, for example, momelotinib versus Jakafi?
So, we didn't really understand, I think, what we were doing initially, in the sense that we knew that the JAK2 mutation existed because 4 independent labs found it and reported in 2005. And then a number of biotech companies, it was a flurry of activity trying to develop inhibitors that would take advantage of this understanding that there was a what we call constitutive, which is just a fancy word that means always on, signaling pathway called the JAK-STAT signaling pathway that should be targeted because maybe it would lead to remissions. And initially in mice that were engineered to have the mutation, the mice had significant improvements when they were given Jakafi. I mean, their spleens went away. They were much happier. And what I mean by that was that they would run around more, they would eat more, like things that mice doctors look at to say, oh, these mice are doing better. So when we saw that data, this was when I was very early on in this field, it was really, really exciting. We really thought we were at the edge of an era of curing patients with myelofibrosis. And of course, that's not exactly what happened. What happened was Jakafi was very successful and very effective in significantly and rapidly reducing spleen and symptoms, not really correcting anemia, not really correcting thrombocytopenia, low platelet count, and not really changing the bone marrow in an appreciable way, and not really leading to molecular remission. So as good as it is, it does fall short because it's not specific to inhibiting the mutant JAK2 protein. And it generally turns down that signaling pathway, but there's good benefit from that. And patients do live longer. And that is something I do believe. Patients treated with Jakafi, particularly patients treated appropriately with Jakafi, meaning optimizing the effects of Jakafi, are more likely to enjoy survival benefit than patients who are not. But that's not because of the classic reasons in oncology. It's not because of remissions. So that was a good step forward, but obviously incomplete. And we now know you don't need to be JAK2 mutated to have that benefit. You could be CALR, you could be MPL, you could be triple negative. And then a number of companies, kind of did the same sort of studies around the same time. Fedratinib is a selective JAK2 inhibitor. So Jakafi is a JAK1/2 inhibitor. Fedratinib or Inrebic is just JAK2. It basically spares JAK1. It's also a FLT3 inhibitor. So these drugs are dirty. They're not clean. When we say JAK2 inhibitor, it's sort of misleading. They're really promiscuous in the sense that they can inhibit a lot of different proteins. And fedratinib or Inrebic inhibits also FLT3, and FLT3 is explained. So now we know a lot more. Like we know that if you inhibit FLT3, that also probably has some beneficial effects on the disease, but also explains some of the toxicity differences. So with fedratinib and Inrebic, FLT3 inhibitor, you get some more GI tox. Very easy to manage, but it's there. Then you have pacritinib, which is also a FLT3 inhibitor. It's also a selective JAK2 inhibitor. It also spares JAK1, but it hits ACVR1 and it hits IRAK1. Now, as a patient, that may be totally meaningless, and I wouldn't blame you. But as someone who's paying attention to this field and who's interested in the translational science of it, what we realize is that sometimes these other proteins that the drugs inhibit are actually meaningful and beneficial in the disease that we're treating. So for example, in myelofibrosis, we think because it inhibits IRAK1, pacritinib, Vonjo, and downregulates what's called NF-kappa B, which is a transcription factor that regulates the expression of inflammatory cytokines, that it's another way of turning off a non-redundant pathway in myelofibrosis that matters. That pathway doesn't extinguish. So the IRAK1 part all of a sudden becomes very important because it downregulates NF-kappa B, and that also contributes to the inflammation. And then the ACVR1 is a really interesting protein that affects what's called hepcidin expression. Hepcidin is a protein that the liver makes, and it controls the intake of iron from the gut into the bloodstream and from certain cells in the bone marrow called macrophages to the hematopoietic cells to make blood cells. And it's very high in myelofibrosis. If you knock that down with an ACVR1 inhibitor, then all of a sudden you can get better blood cell development, better red blood cell development. And so what we see with a drug like pacritinib as a JAK2, ACVR1, IRAK1 inhibitor is you can deliver it in patients with low platelets, and in 25% of patients, you can get clinical improvement in hemoglobin level. With momelotinib, it's a JAK1/2 inhibitor like ruxolitinib, but unlike ruxolitinib, it's an ACVR1 inhibitor. So the drug has been developed specifically trying to address anemia in patients with myelofibrosis. So we moved from an era where we thought it was all about JAK2. We realized, well, there's a lot more to it than that. And there are other pathways that are important. So these, quote unquote, newer JAK2 inhibitors also hit other relevant pathways so they can find niches, whether it's thrombocytopenia, whether it's anemia. So we've moved into an era where we will have 4 JAK inhibitors, and we can find niches where one might be better than the other, perhaps, and sequence them where we might use one right after the other. It gives us a lot of options to play with, and try to address patient symptoms and spleen and anemia.
Yeah, fantastic. This person is a 73-year-old and newly diagnosed with secondary MF. They are largely asymptomatic and have been identified as a transplant candidate. And I wanted to get to transplant, and here we are. Their spleen is quite enlarged and have recently developed cirrhosis-like symptoms. What approach would you recommend to increase the probability of a successful transplant?
All right, that is both complicated and sophisticated in its question. So that's a tricky one. So we see. So some patients can go to transplant if they are, quote unquote, young enough. And young enough today is not what it was when I first started off. So when I first started off, you were too old if you were above 60. And then as things got better and improved in terms of our understanding and our techniques with transplant, it went to 70. And then, I would say now it's 75, and depending on where in the country you live, they'll transplant you if you're 80. So, there's different types of transplants, reduced intensity condition transplants. And as most people who are listening probably can attest to, not every 72-year-old is the same as another 72-year-old. And I meet 72-year-olds that look and act 52, and then I meet 72-year-olds that look 92. And, and where you are biologically may not always be chronologically, so that has to be considered. So we do take patients that are older, and some of those patients might have more baggage, what we call comorbidities, that can complicate things. So that has to be considered. Transplants in myelofibrosis today are almost, particularly in the older population, are almost exclusively reduced intensity conditioning. So we don't slam patients with really hard chemotherapy and make it super difficult. It's easier to get through, and the graft versus host disease management has improved, so the outcomes are better today than they were, but they're still difficult. And one of the challenges is the liver. So livers are important because they detoxify medications, and you get a lot of medications that have the potential for hepatotoxicity or liver issues. So most transplanters will be interested to get some liver studies, make sure the liver going into the transplant is in optimal shape, because that can influence outcome. Now, if you have someone who's got liver disease, or as this person is pointing out, maybe like cirrhosis-like aspects of the disease. It really requires the input of a seasoned hepatologist, a liver specialist, to weigh in and help determine whether it's smart to send someone who's got liver issues into transplant, because that could be a disaster, and or B, how to optimize that person if the decision is to move forward in terms of trying to reduce risk of insult to the liver with medications and provide as much support as possible during the transplant. Sometimes it does require addressing the spleen more aggressively, and sometimes a JAK inhibitor can do that, and sometimes it can't. And sometimes we need to resort to almost what would be considered old-fashioned, but not totally old-fashioned surgery, splenectomy, just taking the spleen out. That has to be done by a seasoned surgeon who really knows what they're doing, not just someone around the corner who's got some scalpels. So you really have to have someone who's got experience in taking out very big, complicated spleens with complicated anatomy. So that's sometimes considered on a case-by-case basis. But the liver part, I think, is one that's complicated and really needs the input of a liver specialist as part of that care team.
Good answer. Can you talk about the latest research on non-driver mutations in MF, such as the Italian findings on ASXL1 in combination with other mutations?
Well, it's an evolving area, and I feel like it's one of those things where, 1 year, the New York Times tells you that drinking too much coffee is bad, and then the next year it's great, and then it keeps changing. Mutations change too, in the sense that I think it's a lot more complicated than we have often originally attributed to it, in the sense that mutations the impact of mutations to some extent depend in the context in which they are sitting. Other mutations, subtypes of disease, other clinical variables. We do know a couple of things for sure, is that if you look at driver mutations alone, there's some differences in survival in just driver mutations. It's favorable to have a calreticulin type 1 mutation, as opposed to have triple negative disease, not have a mutation. We know that there's certain high molecular risk mutations. ASXL1 is one of them. In most myeloid malignancies in this area of the bone marrow, ASXL1 is not a good mutation. It portends a poorer prognosis, but there are other ones like SRSF2, U2AF1, P53, and the problem is that they don't sit alone, and they are subclonal. So they come from the if you can think of myelofibrosis, if you were to collect all the myelofibrosis cells in your body and put it together as a tumor, a ball of cells, there are some cells in that ball of cells that will have this mutation like ASXL1, but most will not. So I think it's more complicated in the sense of it's probably also related to how many cells have ASXL1, what other mutations are present in that ball of cells, what mutations are present within the cells themselves that have ASXL1. It all matters and it all factors out. So right now, I think we're still sort of scratching the surface to understand the complexity of these mutations and what it means. But we do know that there are these high molecular risk mutations. We do know that it does play a role. They are factoring in increasingly to risk stratification tools like the MIPS. Again, you can find these online, and they matter. What we don't have, unfortunately, yet is we don't have drugs that effectively target these mutations. So we don't have an ASXL1 mutant targeting drug, and maybe we don't need one, because maybe the problem is, again, finding the original stem cell that may not have that ASXL1 and getting rid of that guy, because if you get rid of that guy, all the rest will follow suit. So maybe you don't need an ASXL1 directed therapy, you just need a very effective stem cell directed therapy. But nevertheless, we even though we see these mutations and they do help us broadly guide therapeutic decision making, they don't inform, in almost 90% of the time, they don't inform the actual therapeutic treatment decision.
As you know, we have been paying very close attention and started another little segment of our business and our outreach to younger MPN patients. And what we've discovered, yes, many of them have PV and ET, but we do have quite a cohort of patients with MF who are, pediatric. They're not 18 yet, or some of them are up to 23 or 25. Are you seeing a difference when these younger people are diagnosed? Are there any differences in their symptoms? Are the symptoms similar? What do you think that they've had it, were born with it? And I'm going in the direction of the familial studies that are currently underway, and what your thoughts are on familial studies, but also on younger people with being diagnosed with an MPN.
So we used to say, oh, myelofibrosis is a diagnosis of the elderly. And as I get older, the definition of elderly has changed, but also the definition of younger and our understanding of what affects younger people has changed. So we do increasingly recognize, perhaps because there's this general understanding of how to diagnose myelofibrosis and what to look for, and better engagement in the community, that we do find these young people that have MPNs, including myelofibrosis, which of course is always very shocking. And it's bad enough to have a disease like this at any age, older age included. When you have it at such a young age, I think there's a more profound sense of loss of life years in that setting, and that can be traumatic, obviously, for that young person, obviously for the parents who probably have an even deeper understanding of what that means, and everyone around. So I think it's a very sensitive topic, and it's one in which I'm happy to say there are certain people like Nicole Cuchin, who's at Cornell, who's fabulous, who has taken a real interest in pediatric MPNs, because you do need someone who's pediatric focused. And although I see young people, even like I would call them kids, that have these MPNs, we still have a lot to understand. And I always enjoy a pediatric physician's input, because there are a lot of nuances to treating a kid than an adult. We know that these mutations in JAK2, for example, can happen super early on in life, even in utero. So Jyoti Nangalia, who's an amazing laboratory-based physician scientist in UK, did a really outstanding study of patients in UK that had their blood samples banked over a period of time. And she teamed up with some statisticians that did some very fancy modeling. And what they were able to decipher was that the mutations like JAK2 were likely occurring in the stem cells much, much earlier on in life than we expected. Like, when medical students would rotate with me and say, oh, this patient probably started having the disease in the bone marrow a few years ago, because that's the way we thought. Now we realize, no, that's not right at all. They probably were having it decades ago, actually. And the part that's really mind-blowing, that maybe not everyone on the call will be aware of, is that there are people, I won't even call them patients, just regular people that walk around on the streets. They don't have blood count abnormalities. They're not hooked up with a physician. They're not a patient. They're just people. And they have these mutations in their blood. And it's more frequent as you get older. And it's called CHIP, clonal hematopoiesis of indeterminate potential, CHIP. So we know that there are CHIP people walking around, and they are at risk 1% per year for developing a myeloid malignancy, and even higher risk for cardiovascular events. But they're not traditional patients, at least not today, but they will be as our science moves forward. But it also tells us that these mutations are much more prevalent than what we thought, and that they do occur at an early age, and that the reason why maybe a 15-year-old will have myelofibrosis compared to someone at the classic 65 years of age is not fully understood, but there's probably an interplay between where that mutation arose and what type of stem cell, compartment cell, and what other insults that cell might have faced. Inflammatory insults, infectious insults, things that we probably don't understand that influence why the 15-year-old has it, rather than it didn't take 40 more years for it to manifest as an older person. So the field is really exploding with sort of this sense of re-examining how we envision these diseases and the progression from early stages to later stages, early in life to later in life. Because, at some point, I would like to think that we will get to the knowledge point where people will be screened way before they ever get myelofibrosis. They'll be screened, I don't know, when they're young. And if they've got these deleterious cells that are hiding in the background, rather than waiting for them for a chance for those cells to become a blood cancer, they'll be treated with effective therapies then. Now, we don't have that yet. So the reality of our situation is we do encounter kids and young adults, what we call AYA, adolescent and young adults with MPNs and other blood cancers. And it does have pose its own challenges, both socially and ethically, and in a lot of different ways, and how to approach kids like that and what to do. But we know a couple of other things to Anne's question about families. If you have an MPN, your first degree relatives are at higher risk for having an MPN. But it's interestingly not related to the idea that it's congenital, like they were born with the MPN. What it is more nuanced. They're born with a predisposition, an increased risk of developing or acquiring that MPN in their lifetime. And people like Joe Prakal, who's out in Utah, has done a lot of these studies, trying to understand families and their genetics of why. I don't know that we're there. I mean, I'm surely not an expert in that area. But that is an active area, and there are families that have been well documented. Some of them out of Europe that are actually familial MPNs, that they are passed on like in a classic sense. But most patients, it's acquired, and it's not unusual to find relatives in their family tree that might have an MPN. Now, what I don't want to do is scare anyone who's listening to think, oh man, I got my kids are are going to develop MPNs. No, your kids are still very unlikely to develop an MPN. They are more likely than the kids next door if their parents didn't have an MPN, but they're not likely to develop an MPN. So I don't want to instill any anxiety about their kids' future. But it's one of those things where I think, if you have an MPN, your offspring and your brothers and sisters should probably be vigilant in the sense that they should see a doctor, get their blood counts checked. They don't need bone marrow biopsies, but they should have general health maintenance, and they should just be aware of that. And we're not at the point where we meaningfully intervene yet.
Mm-hmm. So two things: we are partnered with Nicole Cousin and with our pediatric and young adult program, and Linda Razar from Johns Hopkins, and there's so much going on. It's just incredible. And so we talked a little bit about interferon. You touched on that a little bit. And is that a option for you for certain patients? Or, I mean, how do you determine who is going to be a candidate for interferon? And that could be Pegasus, or now we have Besremi. What are your thoughts on that?
I think, well, I'm a moderate in so many ways. I'm definitely not a over enthusiast, nor am I a Debbie Downer. I think interferon has its role, a very prominent role, particularly in polycythemia vera, and increasingly, I think we're seeing in essential thrombocythemia. We're waiting for some of the phase 3 results from the SURPASS study with Besremi to result, but I use it pretty frequently, I would say, in ET and PV. I do think it has a role in myelofibrosis, particularly the pre-fibrotic form of myelofibrosis, or in early patients with myelofibrosis. I'm less impressed about using interferon in patients who have advanced myelofibrosis. But having said that, the French, mainly led by Jean-Jacques Kalagin, but also investigators from Northern European countries, like Dr. Hasselbach and colleagues, have presented data with combination approaches of interferon plus Jakafi, which have looked intriguing and promising in terms of offsetting some of the toxicities with interferon with Jakafi, but also some synergistic clinical activity. So I do think that there's a potential role for interferon early on in the disease, maybe as a single agent, maybe even later in the disease as a combination. I'm a believer in clinical trials. So I think until we have really firm, very believable, well-powered clinical trials to give us that that evidence and that confidence to make it, an approved and labeled indication, I would encourage patients, if possible, I would encourage patients to enroll in such clinical trials to contribute to the process. I also just want to make a plug for clinical trials. I'll just take this opportunity right now. I think there's often a misconception, in my opinion, in my biased opinion, but in my opinion, about clinical trials. Clinical trials are not, are not meant to be, patients will sometimes think, oh, I don't want to be a guinea pig on a clinical trial, but actually I see it very differently than that. Clinical trials give an opportunity to get drugs in a controlled and intelligent and informed fashion that have the potential to be better than standard of care. And I really think that patients who are on clinical trials ultimately do better than patients who are not, because when you're on clinical trials, there are multiple levels of observation, monitoring, and regulation from the government down to the local institution, to the investigator, to the research nurses. There's a lot more eyes on you. I do think patients who have a lot more eyes on them do a lot better than patients who have less eyes on them. So that's my plug for clinical trials. Don't consider it a guinea pig. And the other thing, if you have a wider view than yourself, is that clinical trials do help the greater community. So when you participate in a clinical trial, you are doing it, yes, first and foremost to help yourself, as one should, but there's a benefit to the greater community. And I'm always blown away, and I'm always in awe of, because there's a certain degree of courage, I think, and bravery to enroll in a clinical trial. And I'm always blown away by people who go out of their way to do a clinical trial when they could have taken the easy route. And I'm not criticizing people who go on commercial drugs at all. But when, some people will go out of their way in many ways to participate in a clinical trial because they do believe in the idea of helping, the community, and they see themselves as part of the community. And that always moves me when people have that motivation. But clinical trials is the way to go. I think if interferon is to continue to move forward in myelofibrosis, I think we need to see more of that data in clinical trials. So I would encourage patients to, in an informed fashion, get involved in clinical trials.
Yes, if they can. We're big proponents of that ourselves, but we also know the barriers and, some of the challenges for the average person to participate.
Absolutely.
But I feel the same way. I think, these people are saints and they do get excellent treatment and care during that process. What is your opinion about treating MF and variable anemia with Jakafi and danazol?
So Jakafi is a great drug for spleen and symptom. It's not really a great drug for anemia. Danazol is a drug historically that has about a 20 to 30% anemia response rate. It's an oral drug. It has to be used correctly. You start at 200 once a day, then you go to 200 twice a day, 400 milligrams, and then 200 3 times a day, 600 milligrams each week if the drug is being tolerated. And you got to be on it for about 6 to 8 weeks at 600 milligrams to really give it a fair chance. And it can improve the hemoglobin. Sometimes it's mild and moderate and it's not that impressive. Sometimes it's more impressive. I've had patients go for years with really good effects with danazol, but it's the minority of patients. And it does have some toxicity, whether it's hepatotoxicity or some swelling, some edema, rash can be seen in some patients. Like any other drug, not every patient enjoys the benefit, and not every patient escapes from the toxicity. There is phase 2 data. So Ruben Mesa and myself did a phase 2 study between when he was at UT San Antonio and Mount Sinai. We enrolled patients with myelofibrosis on ruxolitinib and experiencing anemia and gave them danazol. And it was not a positive study. Now I can say anecdotally, I've had patients who have done wonderfully with the combination, but the way the study was designed, it didn't meet its primary endpoint of anemia response in sufficient number of patients. So danazol doesn't seem to get in the way of spleen and symptom benefit. You still get that, doesn't impair that, but it's variable in terms of how well someone will respond in terms of anemia. So I do consider it a drug to consider in using, particularly if you have anemia and you're enjoying spleen and symptom benefit, maybe adding the danazol to the ruxolitinib, to the Jakafi. But unfortunately, I wouldn't call it a home run. It's it's a step forward.
Okay. What are your thoughts about Dr. Silver's article in 2016 noting that a large spleen causes high risk of neutrophil and platelet engraftment, and high LDH causes high risk of platelet engraftment with a stem cell transplant?
So there are many studies and papers that have tried to evaluate whether big spleens are detrimental to the transplant outcome. And I will say that the data is really all over the place, actually. So there's a couple of things we know is that when you transfuse stem cells into someone, and that's what a transplant is, it's not surgical, it's really giving chemotherapy, maiming someone's immune system just long enough that you can transfuse, like a red blood cell transfusion, transfuse a bag of stem cells into their body, and then those stem cells should go to the bone marrow and make a new immune system, a new hematopoietic system, new whites, reds, and platelets from the donor. And then that immune system is supposed to kick out and get rid of the residual recipient stem cells to cure the patient. There's always been a concern that if you have a very big spleen and you transfuse in those stem cells, they're just going to get caught up in the spleen and not get to where they're supposed to be. And the data is very conflicting of whether that's true. But it has been a concern, and for that reason, and it's somewhat made up, in a lot of centers, they want a spleen less than 10 centimeters below the rib cage. And to do that, often JAK inhibitors can be used, and there's a number of studies have looked at JAK inhibitors like Jakafi prior to stem cell transplant. What I can say is it doesn't adversely impact the stem cell transplant. It's not clear it improves stem cell transplant. So even if you have super shrinkage of your spleen with Jakafi, data is not that clear that you get better engraftment, actually. But there was a time in history, in the US at least, where most patients would get a splenectomy before transplant. Just get rid of the spleen and then just transfuse the cells in. That has kind of fallen out of vogue. It doesn't seem to really be necessary. And stem cells are, they're persistent. If they want to get into that bone marrow, as fibrotic as it is, and big as your spleen is, they will figure it out. So a lot of centers are less aggressive with the spleen lowering, spleen reducing, spleen removing approaches before transplant. I will say it seems to be transplanter specific about how, what they feel like for individual case. But I think that patients who have a big spleen or a high LDH are patients who have very advanced disease. Patients who have very advanced disease are in general sicker and harder to cure than patients who have less advanced disease. So I don't know if it's nuanced. What I'm trying to convey is I'm not sure that it's necessarily the size of the spleen or the height of the LDH. I think it's what it reflects. There's surrogates for patients who have worse disease, and patients with any worse disease are harder to cure than patients who have earlier disease.
Makes sense to me. What is the clinical significance of the percentage of mutations found in a bone marrow biopsy? Does the increase of mutations in number and percentage have an impact on prognosis?
So we know that, like I was saying, mutations matter. They do have prognostic impact. So some don't. So we've looked at lots of different mutations. There's people that their careers are based on studying mutations and understand. It's called bioinformatics, understanding how to make sense out of it because it's complicated. And there's a lot of different mutations. And there are certain mutations that just seem to be neutral. They don't seem to have any effect, like TET2, very common mutation, but I've never seen a study that tells me that TET2 is bad or good. It just seems to be there and doesn't do anything. But if you start to accumulate mutations, it does signify or imply a more biologically complex disease. And there is data that suggests that if 2 or more high molecular risk mutations, your prognosis is even worse. It's even more heavily weighted. There are studies that would suggest that you have 3 or more mutations of certain mutations present. It has an influence on response rates with Jakafi. So the more mutations, perhaps the less likely you will respond, or the shorter the response may be with Jakafi. So the mutations are looked at, they are used. I think they're incompletely understood. They do have some prognostic impact. They do have some therapeutic considerations, but they're far from prime time where we can use them to create a very specific, very tailored, very effective treatment plan just based on the mutations.
Okay. The benefits of navitoclax appears to happen over a long period of time. What is the time frame you have seen for the full benefits to be realized?
Well, I think for most of the studies, navitoclax included, the primary endpoint is usually 6 months. It's 24 weeks when you look at spleen and symptom. Now, what the question might be getting to is, do all patients get that benefit within 6 months, or are there late responders? Does it take longer for other patients? And the answer is always yes. There are late responders. There are patients who respond very quickly to these drugs within weeks to months. You can see very dramatic responses, and that's been well documented with all of these drugs. But then there are some patients that take longer. But generally speaking, if we don't see spleen and symptom benefit, measurable spleen and symptom benefit within 6 months, we tend to say that that's a failure. We tend not to just hang on. I think in a world, if we didn't have a lot of options and things to move to, we would potentially just keep giving the drug with the hopes that there will be this proportion of patients that will get a late benefit. But if we're not seeing it at that time point, we tend to move on. So I think that the answer to the question is that most patients are going to benefit within the first 6 months. If you're not, probably going to go on to something different. I think.
Yeah. This question is about Agent Orange and the link to MPNs, and Dr. Ron Paul and I have partnered on that issue, and we kind of let it lay for a while, but I just want to say to this person, don't fret, because at ASCO, there was a paper that was written by several scientists looking at the link between MPNs and Agent Orange. So very specifically for the first time. And Dr. Ron Paul and I will be meeting with one of the authors of that. So I'm just letting this person know, hang in there, because we needed evidence with the Veterans Administration, scientific evidence that there was a link. And the only thing we had was a link between benzene and the use of benzene in Vietnam, and it was actually used to liquefy Agent Orange at times. So hang in there, whoever this is, we're working on it. Okay, so John, we are at the hour mark, which you're welcome. I still have other questions for you. And how about if you started out by telling us, so many different things that are happening in the MF world of clinical trials and so on. But if you would like to take a few minutes and just share with us, from my experiences of 20 years in this space, and of course yours approaching that or near that, we both have seen tremendous changes, and the earth is always moving under this MPN community. But what would you leave the patients and caregivers that are on this webinar, listening to this webinar? What would you like to share with them in terms of the hope for the future, and anything else that you'd like to share?
I think a sentiment that I've shared at similar meetings and in person with patients that I meet, I think that there's a significant difference today than when I first started here in terms of the understanding, the approach, the collaboration, which is really essential. So collaboration between investigators working together across centers across the world, that's not always the paradigm, and that's super important with a rare disease. You can't do it yourself. You shouldn't try to do it yourself. You need the help and the assistance to do that. And it's really through teamwork that we make this progress. The inclusion of patients and patient advocacy groups, such as this group, in the process is really key, because we're here to serve patients. If you're not part of that discussion, asking the questions, reporting things, participating in clinical trials, we're not going to move anything forward. So it's really a close participation between many investigators, many centers, patient advocacy groups, industry. Thankfully, we live in a capitalistic world, and the reality is, if you have a rare disease, that incentivizes drug development, and that's a big motivator for companies to to put a lot of money, a lot of resources, energy, very smart people behind the scenes into this field and developing drugs. And we need those people because they have the drugs and we need access to the drugs. We need the patients, we need their buy-in, we need their support, we need the government. So thankfully the NIH still helps us. For example, the PO1 MPNRC is an NCI funded grant that I firmly believe is a pharma independent translational machine that brings new findings into the clinic, and we've done that for 15 years, and I think it's like a whole movement of people, and I see that today, and I've watched that evolve, and it's been very, for me personally, very gratifying to see it as a physician who treats a lot of patients and has been personally affected on a daily basis by being part of patients' lives, and it's been huge to see that evolve, to see us go from nothing to a JAK inhibitor, multiple JAK inhibitors, now combination therapies, improvement in transplant outcomes. But obviously, we still have a lot more to do. But I don't see that excitement in making it happen. I don't see that interest, that passion waning. I feel like, if anything, it continues to be on the rise. The pandemic hasn't stopped it. The current economic and political situations haven't stopped it. So, I think I'm enthusiastic and I'm optimistic that we will continue to see, more improvements over the next 5-10 years. And, dare I say, hopefully in my lifetime and the lifetimes of people on this call, we'll see things that are super meaningful, like cures, functional cures and remissions. So hang in there and believe that the system actually works. It's working.
Yeah, I couldn't agree more. And we have always said we have to be transparent. We need to work together. The patients, the physicians, and industry, or nothing would happen, and we would be at a standstill. I cannot thank you enough. We're moving on to hear from our industry partners, which would make all of this possible for us. And but you've kind of set it up so well, because we've talked about a lot of the drugs that are in the pipeline right now. And I always encourage people, the patients and caregivers, to remain with us to hear from these partners. You've backed up so much of this, and now to hear what's happening in their space, and to help the MPN community, and to facilitate the new treatments, and that I hope will be coming around soon. We already have so many. So many are coming down the pipeline. It's just been amazing. And so you are welcome to stay with us, John, or if you need to get back to your lab or to patients, that's fine. We're going to hear from Insight first. And we talked a lot about Jakafi today. Kristen Griffiths is the Associate Director of Communications and Patient Advocacy. Hi, Kristen.
Hi, can you hear me okay?
Yes, sure can. Thank you for being with us.
Oh, no, thank you so much for having me, Anne. I'm so very pleased to be here, and thankful to you and the organization for having me and giving me a few moments to speak about Insight and its commitment to patients. So a little bit about Insight. We are a Wilmington, Delaware-based biopharmaceutical company, and we're really committed to making a difference in the lives of patients through scientific discovery. Rigorous science is at the core of everything we do to discover, develop, and deliver novel medicines that treat and meet the needs of serious medical diseases in oncology and other disease states as well. Just a note on patient access. So one of our most important commitments is to help ensure that appropriate patients may have access to the medicines that they need. So for this reason, we've developed a patient support program called Insight Cares to help appropriate patients and their healthcare providers access their prescribed medications. So for eligible patients, Insight Cares offers prescription drug insurance verification, prior authorization support, free drug and copay assistance for those who qualify under the program's terms and conditions, and also an ongoing support from education and educational support from a representative. So if you are a patient and you have any concerns about access to your prescribed medications, please contact Insight Cares for assistance. And this information can be found at insightcares.com. That's INCYTE cares.com. And we highly suggest that any eligible patients enroll in Insight Cares because circumstances can change. So even if you don't need these assistance immediately, you'll be able to be supported more quickly if you're already enrolled. And I'd always like to talk about community support, since that's very important to what we do at Insight. And we always strive to enhance the patient community and integrate an authentic patient voice throughout our initiatives. We really thoroughly appreciate the partnerships we have with MPN Advocacy and Education International, and helping us understand the unmet patient need as well as caregiver needs, including raising disease awareness and providing educational information to the community. So we host a website called voicesofmpn.com, where we provide access to information such as patient stories, information about MPN community events such as Facebook Live events, patient meetings, podcasts, and also a symptom tracker. So tracking symptoms is really key for identifying progression. So we've created an app that can be downloaded on voicesofmpn.com, or you can actually find it on the Google Play or Apple App Store. And this is a tool that will help you track your MPN symptoms. And you can download it and start today. It's free for you to use. And one last shout out I want to give is to the MPN Heroes program. So we developed this program which publicly recognizes individuals who have excelled in caring for patients or patients with the MPN and MPN, or those who have advanced the science in MPN. So special shout out to Anne and Dr. Mascarenhas, who are both former recipients of this honor. And the nomination window is now open, and it will be open for a few months. So if you have an MPN hero in your life that you'd like to nominate, please go to voicesofmpn.com and nominate your hero. And finally, just a couple closing words. We at Insight believe industry and patient groups can find common ground and develop collaborative partnerships resulting in meaningful activities. So it's programs like this that allow Insight to use our resources to help improve the patient lives and individuals impacted by diseases in which we work. So thank you so much for the opportunity, and back to you.
Thank you very much for your support. And I do have to say, Insight Cares is a great program. I can't believe how high it's just accessible to many, many patients if they need help. So thank you.
Thank you for that.
Very much. We will move on to AbbVie and Virginia Tejero, who is the Associate Science Director. Hi again. How are you?
Hi, Anne. It's good to see you.
Good to see you as well.
Thank you. And thanks to MPN Advocacy and Education International for allowing me to discuss AbbVie's clinical myelofibrosis program with you today. My name is Virginia Tejero, and I am an Associate Scientific Director in U.S. Medical Affairs at AbbVie. AbbVie is a global pharmaceutical company and a leader in the transformation of care for patients with blood cancers. We are striving to advance standards of care and bring transformative treatment options to patients, including those with myelofibrosis. We are currently evaluating navitoclax in myelofibrosis, and please note, navitoclax is an investigational agent and not currently FDA approved. Safety and efficacy are still under evaluation. So navitoclax is a first-in-class oral small molecule that binds to two proteins called BCL-XL and BCL2, which are pro-survival proteins that prevent cells from dying. Cancer cells can hijack the machinery that makes these survival proteins to keep themselves alive. And navitoclax binds to BCL-XL, which can cause myelofibrosis cells to die. JAK inhibitors shut off the pathway that increases production of BCL-XL, making myelofibrosis cells susceptible to BCL-XL inhibition. Given the results seen in the phase 2 REFINE study, AbbVie has proceeded with 2 phase 3 studies in fall 2020, both evaluating the combination of navitoclax and ruxolitinib in myelofibrosis in a larger patient set. The first study, Transform-1, includes patients with myelofibrosis who have not received prior treatment with a JAK inhibitor and is evaluating the safety and efficacy of navitoclax combination with ruxolitinib versus placebo and ruxolitinib. The second phase 3 study, Transform-2, is currently seeking more patients to participate. This study includes patients with myelofibrosis who have worsening disease as evidenced by an enlarged spleen and symptoms despite previous or current treatment with a JAK2 inhibitor. Transform 2 is an open label study, meaning patients and investigators will know what agent they are receiving and will evaluate combination of navitoclax and ruxolitinib versus the best available therapy, which is at the discretion of the physician and could include ruxolitinib, fedratinib, among other options. We currently have more than 30 sites across the US for each study, and Transform 2 is still seeking patients to participate. You can find more information regarding the ongoing studies at www.myelofibrosisresearch.com. This site includes further information about each study, a questionnaire to determine if you might be eligible to participate, and a map of current site locations. Thank you very much for your time, everyone.
Great. Thank you very much, Virginia. We appreciate it. And we'll move on to Imago Biosciences, which is now a subsidiary of Merck & Company, Inc. And our pal, Alicia Shilton-Lloyd, who is the Vice President of Medical Affairs. Hi, Alicia.
Hey, Anne, what a mouthful, right? Like, we just keep adding more and more and more to everything, and our name already is hard enough. So as you mentioned, Anne, I'm Alicia. I head up the medical affairs and patient engagement team at Imago Biosciences. We are a subsidiary of Merck & Co. Incorporated, and we are a clinical stage biopharmaceutical company developing new medicines for the treatment of MPNs and other bone marrow diseases. Our lead candidate is bomedemstat. Bomedemstat is an investigational, once-a-day, oral, lysine-specific demethylase-1 or LSD1 inhibitor. LSD1 is believed to play an important role in the maturation of blood cells in the bone marrow. Bomedemstat is an investigational agent, which means it's not yet approved by the FDA for use outside of clinical trials. Over 200 patients have been treated with bomedemstat in multiple phase 2 clinical trials for the treatment of essential thrombocythemia, myelofibrosis, and polycythemia vera, in addition to other indications. We presented the latest data on these trials in December at ASH, which is the large annual conference here in the US, where the latest data on blood cancers and other blood disorders is often shared. As always, we share the data we presented with the MPN Advocacy and Education International team, including plain language versions of this data. They are always a great resource to find out the most current information on any treatment agents and regimens. As shown in the data we presented, the clinical activity thus far warrants continued investigation in a phase 3 study. We will be shortly initiating our phase 3 trial in ET in over 20 countries, including here in the US. We've recently initiated a phase 2 trial in PV in the US, UK, and Australia, and are currently seeking more patients to participate. And relevant to the conversation today, there is an ongoing phase 2 study of bomedemstat in combination with ruxolitinib in patients with myelofibrosis. And we at Imago and the doctors and patients and participants that we've partnered with in our trials aren't the only ones excited about these trial results and the data that we have so far. On January 11th of this year, we were acquired by Merck, as you might guess from the background I'm using today. I'm delighted to share that bomedemstat is now part of the Merck pipeline. We're working together to integrate Imago into Merck, and this has opened up incredible opportunities for us to further explore the unmet needs and the true priorities of MPN patients. And as always, we will be working with Anne and the MPN Advocacy and Education International team to make sure that we are hearing what patients are saying, we're sharing data in a transparent manner, and we're continuing to work forward as a community to bring the best treatment agents and options possible forward. Anne, thanks so much for your time today.
Thank you, Alicia. I really appreciated you being with us. Thanks. And I'll see you soon, I hope. Okay, so we'll move on to GSK and Susie Seitman, who is the patient engagement liaison. Hi, Susie.
Hi, Anne. Thank you so much for having me this afternoon. As you said, my name is Susie, and I am a patient engagement liaison with GSK Oncology. GSK is a global biopharma company with a purpose to unite science, technology, and talent to get ahead of disease together. GSK is focused on maximizing patient survival through transformational medicines. Our focus includes immuno-oncology, cell therapy, tumor cell targeting therapies, and synthetic lethality. Our goal is to achieve a sustainable flow of new treatments based on a diversified portfolio of investigational medicines, utilizing modalities such as small molecules, antibodies, antibody drug conjugates, and cell therapy, either or a combination. In July of 2022, GSK completed the acquisition of Sierra Oncology, a California-based biopharmaceutical company focused on targeted therapy treatment forms of cancer. The acquisition of Sierra Oncology includes momelotinib, a late-stage potential new medicine with a unique dual mechanism of action that may address the critical unmet needs of myelofibrosis patients with anemia. In August of 2022, GSK announced that the FDA accepted the new drug application, or NDA, for momelotinib. If approved, momelotinib will contribute to GSK's growing specialty medicines business, with a U.S. launch anticipated in June of 2023. The NDA is based on the results from key phase 3 trials, including the pivotal MOMENTUM trial. The primary analysis data from the MOMENTUM trial were recently presented at the 2022 American Society of Clinical Oncology, ASCO, annual meeting, and the European Hematology Association 2022 Hybrid Congress. To close, I'd just like to add that we are so grateful to Anne Brazou and the entire myelofibrosis advocacy community for all the work you're doing to raise awareness and educate patients and their care partners about this disease. We appreciate the partnership that we have with you, MPN Advocacy and Educational International, and I thank you for this opportunity to tell you and your listeners about what we are doing at GSK Oncology. Thank you.
Thank you, Susie, very much. Thank you. We appreciate the partnership also. Okay, so we'll move on to CTI Biopharma and Deb Hoyer, who's the Principal Medical Science Liaison. Hello there. How are you, Deb?
Good afternoon, Anne, and the entire MPN Advocacy and Education team. As Anne shared, my name is Deb Hoyer, and I'm a Principal Medical Science Liaison at CTI Biopharma. First, congratulations on celebrating your 10th year. And also, thank you for hosting this educational event and for giving us the opportunity to provide an update about our work here at CTI. We recognize, as it was mentioned earlier, that it takes patients, clinicians, and industry to work together to improve therapies and patients' lives, especially in areas of unmet medical needs like in myelofibrosis. Patients who have myelofibrosis and cytopenias, low platelets, and red blood cells have limited treatment options until last year when pacritinib, a JAK1 sparing, JAK2 IRAK inhibitor, received accelerated approval by the Food and Drug Administration, the FDA. Pacritinib, marketed as Vonjo, an oral drug taken twice daily, is approved for use in adult patients with myelofibrosis with very low platelet counts, meaning less than 50,000, because we recognize that these patients have more advanced disease and many can only tolerate a fraction of a dose of a currently available treatment. The approval of pacritinib was based on efficacy results from a pivotal phase 3 PERSIST-2 study, the only study that included patients with platelet counts less than 100,000 and no lower limit. PERSIST-2 compared pacritinib at 2 doses to the best available therapy, which included ruxolitinib. As part of the accelerated approval, CTI is required to describe a clinical benefit in a confirmatory phase 3 trial called Pacifica that's enrolling in the rest of the world, but not in the US. This weekend, the National Comprehensive Cancer Network, NCCN, updated the guidelines now to include the use of pacritinib first line for patients with platelet counts greater than or equal to 50,000, category 2B. Our pursuit of advancing novel treatments for blood cancers begins with pacritinib. At CTI, we continue to explore pacritinib's unique mechanism of action and impacts on cytopenia. In December 2022, at the American Society of Hematology, the ASH meeting, emerging retrospective data from the PERSIST-2 study was presented by Dr. Stephen O. This data assessed pacritinib's impact on transfusion independence and ACVR1, which is a receptor kinase that controls the expression of the peptide hormone hepcidin. Hepcidin reduction helps lessen the anemia of inflammation that occurs in myelofibrosis. Data show that pacritinib is a potent ACVR1 inhibitor, in addition to having the JAK2 and IRAK1 inhibition. This unique kinase inhibition profile for pacritinib potentially offers a dual mechanism for the improvement of anemia. Additionally, the ASH data showed that a significantly greater portion of patients on pacritinib, 200 milligrams BID daily, compared to best available therapy, achieved red blood cell transfusion independence over any 12-week interval through week 24. Also, the percentage of patients who achieved a greater than 50% reduction in the transfusion rate over a 12-week interval was significantly higher on the pacritinib arm compared to the best available therapy. These preclinical and clinical data suggest an important role for pacritinib in addressing anemia in patients with cytopenic myelofibrosis. CTI is committed to ensuring that eligible patients can access pacritinib through a comprehensive patient support program called CTI Access. The website address is ctiacces.com, and our team is enthusiastic about our partnership with MPN Advocacy and Education International. We continue to support rigorous science and the data that will be bringing much needed treatment options to patients living with myelofibrosis, with the goal of improving symptoms, spleen response, and providing hematological improvement or stability. I would like to thank you, Anne, and the MPN Advocacy and Education International Group, patients, families, caregivers, and my pharmaceutical colleagues. Thank you.
Thank you, Deb, very much. Thank you very much. We'll move on to Morphosis and Elsa Levita, who's the Director of Patient Advocacy. Hi, Elsa.
Hi, Anne. Thank you for your partnership and the opportunity to be here today. Morphosis began as a research and technology provider over 30 years ago in Germany. And today we've evolved into a fully integrated commercial stage biopharmaceutical company based in Munich, Germany and Boston, Massachusetts. We're focused on the development and delivery of innovative cancer medicines. Our pipeline consists of investigational cancer medicines in mid to late stage development. This includes pelabresib, our investigational BET inhibitor, which Dr. Mascarenhas spoke about earlier. Pelabresib is currently being explored as a first-line treatment option for people living with myelofibrosis in phase 2 and phase 3 clinical trials called MANIFEST and MANIFEST-2. MANIFEST-2 has recently reached full enrollment and is no longer recruiting. Pelabresib is an orally administered small molecule, or in other words, a pill, designed to inhibit the activity of a family of proteins called proteins, which contribute to abnormal gene expression in myelofibrosis. Inhibiting or hindering the activity of these BET proteins represents a potential therapeutic approach to myelofibrosis. As we present data from MANIFEST and MANIFEST-2, we will work closely with Anne and team to ensure regular and timely updates on our studies are shared. We will have top-line data from MANIFEST-2 by the end of 2023. As a reminder, pelabresib is an investigational medicine not approved by any regulatory authority, and there is no guarantee that it will be approved. At Morphosis, we are honored to work closely with patient advocacy organizations like MPN Advocacy and Education International, serving the blood cancer community. We strive to aid the community by creating and supporting programs that provide education, services, and tools to people diagnosed with myelofibrosis. And we engage with the community through forums such as this one today to understand the patient perspective and journey so that we may incorporate those critical insights into our research and development efforts. Thank you again for your partnership.
Thank you for our partnership. We appreciate it. We will see you soon, I think. Very soon, actually. Thanks, Elsa. And we'll move on to Protagonist and Lindsay Kahn, who is the Director of Medical Science Liaison. Lindsay.
Okay. Hi, everybody. Thank you, Anne.
Hello.
Let me see here.
Okay, so I'm going to be short and sweet here. Thank you for having me here today. As you mentioned, I'm Lindsay Count. I'm one of the medical science liaisons from Protagonist Therapeutics. We are a biopharmaceutical company located in the South San Francisco Bay Area. We are a small growing biotech with about 120 employees. So I'm going to talk to you today about a trial in polycythemia vera rather than myelofibrosis. Our drug discovery platform is based on a proprietary peptide technology, and our lead investigational drug candidate is rusfertide, also known as PTG-300. It is a synthetic mimetic of the natural occurring hormone hepcidin. Hepcidin regulates iron metabolism and controls the absorption, storage, and distribution of iron in the body. We are excited to announce that our phase 2 revived study, which compared rusfertide to placebo in 70 polycythemia vera patients, was recently unblinded and yielded positive results. As a result, we have moved forward with a phase 3 trial for patients with polycythemia vera. The trial, called Verify, has already begun and is currently enrolling. We are targeting 100 sites globally and are looking to enroll 250 PV patients. This Verify study allows both high-risk and low-risk PV patients to enroll and is considered an add-on trial. Rusfertide is added on to the normal standard of care. It is a randomized placebo-controlled trial evaluating the safety and efficacy of a once-weekly subcutaneously self-administered dose of rusfertide in polycythemia vera patients. If you're a PV patient, we have a patient website where you can go and answer 9 questions, which will help you determine if you qualify for the study. It'll also show you the cancer centers that have the study open near you within 150 miles. The website is www.polycythemiavera-clinicaltrial.com. So that's our trial in a nutshell. Thank you, Anne, for such an interesting and informative program today, and for letting me speak on behalf of Protagonist Therapeutics.
Thank you very much, Lindsay. We appreciate it. And last but not least is Pharmacentia and Dr. Ray Urbanski, who's the Senior VP of Clinical Development and Medical Affairs. Hi, Ray.
Hi, Ann. How are you?
I'm good. Thank you. Thanks for joining us today.
I must admit, I always enjoy John's presentations, and especially his approach to clinical trials and telling people and patients and caregivers how important they are.
Absolutely.
It is. So I'll talk a little bit about Ropeg Interferon, which is basically marketed as Besremi. As I mentioned many times, it's a purposely designed monopegylated interferon, which differentiates itself from the other interferons that are out there, such as Pegasus, for example. And Ropeg actually works very specifically at the JAK2 mutated stem cell that is in your bone marrow. So it's actually not treating just a sign or a symptom of the disease, but it's actually treating the disease itself. And when we looked at our data across multiple studies, you can see that all counts diminish, not only the red blood cell count or the hematocrit, but also the white count, the platelet count. And studies done by investigators such as John has shown that other blood counts, such as the white blood cell counts, can become very important when you look at the treatment of PV. So I'm going to try to focus now a little bit more on the myelofibrosis side of things. For the most part, Pharmacentia has been involved in polycythemia vera and essential thrombocythemia. We just recently started getting involved in the myelofibrosis area. Now, as you probably know, Besremi was approved in November of last year, and somebody mentioned the NCCN guidelines. Besremi was actually just listed now as a preferred agent in the treatment of PV, both in low and high risk patients requiring cytoreductive therapy. So with the exciting results that we got from ET, that we got from PV, we decided to look at in myelofibrosis. We started with an initial grant given to an investigator, my accent gets the better of me sometimes, an investigator in Hong Kong, where we showed very dramatic results in pre-fibrotic and early MF. And so we decided to move forward, and we are now pulling together a clinical trial program that's actually going to be looking at using Besremi in the treatment of myelofibrosis. And one of the things is we're going to be looking at a dosing regimen that's slightly different than the one that's in our current label. This will be a study looking at endpoints at around 52 weeks, or basically a year, looking at blood counts, the platelet count, the white count, as well as the patient's total symptom score. I don't have more details about this, but when it does become available, I will present it and at your future meetings. But some of this information can be seen on our website for patients that are interested. So with that, thank you very much, Anne. And John, as always, I appreciate and really do learn every time you present.
Yes, thank you very much, Ray. We really appreciate our partnership as well. And John, I can't thank you enough. I think you're still with us somewhere here. And there you are. Hi. Thank you, thank you, thank you. You and I corresponded quite a bit to finally make this happen. And I so appreciate you and appreciate your time. And I'll be in touch very soon. Thank you.
Thanks for having me, and I hope everyone has a great day.
It was great. Thanks. Take good care.